Good morning. Yes, we are good morning.
We are good morning.
That's where we
Hello.
are.
That is true. It is 7 a.m. here and 10 a.m. there, and that would constitute morning. So, good morning, dear Dr. Rosensweet. Again, to all the women and men that'll come up in advance. And we have our questions and we can get started.
All
Yeah?
right.
All right. Okay. So, again, back to our Testosterone Tuesday, now DHEA Tuesday. Um, Question number one comes in. Prior to supplementing with hormones, my DHEA levels were really high and way out of range. I have been supplementing with estrogen, progesterone, and testosterone, have never been put on DHEA. Is it abnormal to have high DHEA? And could testosterone maybe be the culprit here? Uh, in re-DHEA, is it bad to have high DHEA? And two, what would cause it to be so high?
Um, there's some missing pieces of information here. It's unusual to have an elevated DHEA for women and men, and it does exist.
Mm,
And it's usually not super high. And when in doubt, I do a 24-hour urine hormone test because in understanding DHEA, it's crucial biologically to understand everything that is part of the DHEA family, otherwise known as the androgens. So you
right.
want to know the two principal androgens, which is the testosterone level, the DHEA level, and at least the two principal metabolites of testosterone and DHEA. Principal metabolite of testosterone is androsterone, and the principal metabolite of DHEA is ethyl-calanolone. Although these things are interchangeable and they're not totally fixed, you can get a lovely, amazing look at what that family really looks like. When you're drawing blood, you're drawing in 1 microsecond of time. You're not, and it depends when you're drawing. So that's a problem.
Okay.
And as far as assessing hormone levels go, you could have had a little bit of stress just from the needle coming at you, and your adrenal glands activate and you produce a high level. So, to take care of that, to totally rule that out, we do a 24-hour urine hormone test. We look at the whole androgen family. It's pretty rare to have a significantly elevated DHEA 24/7, 24 hours a day. Does it exist? It does exist. Rare is an adrenal tumor
Mm,
that's actually producing hormones. And I have suspected that, and I've seen it twice. And I actually saw it on 24-hour urine hormone testing. And I went, "Wow, these are pretty rich numbers here." And we went and did we had a special radiologic imaging study. I think it was a CAT scan, and saw a small tumor, and the woman had that tumor removed. And we picked it up on a very, very small level. The anesthesiology commented to the patient that he had never seen an adrenal tumor found at that small, which is a great thing to find them small.
yeah.
Most adrenal tumors, by the way, are not cancers. They're benign tumors, but they can secrete hormones. Now, having said that, you can erase that from your mind pretty much because that's very, very unusual. Another thing that can happen is there can be a genetic propensity to have higher DHEA levels and androgen levels than the general population. We saw this first in an Italian, and then we saw it, and we tested a second member of his family, and they had it too, and it was obvious that this was just a genetic variation.
Yeah.
These things weren't way out of range, but they were a little elevated. Now, having said that, those are rare exceptions. One thing that can raise the DHEA as well as any of the adrenal hormones is fight or flight. So if you're walking out your front door today, questioner, speaking to the woman who's asking this question, and you meet up with a saber-toothed tiger, here's our best advice. Run back in the house and close that door.
Just gonna get the
And,
heck out of there.
and really hope that it's a strong door.
Send him next door.
Now, even if you do run back in the house and slam your front door, you're still probably going to have activated the fight or flight biochemistry to make you powerful, more awake, more alert, more powerful. And that's going to be an outpouring of a lot of different hormones, including DHEA and testosterone. And if you can raise your DHEA through the stress response, good on you. Good on you, mate, because it shows that you still have some oomph in the adrenal glands. Not all adults do. Many of us have put such a strain on our adrenal glands that by the time we're midlife, these adrenal hormones, including DHEA and testosterone, are reduced. They're not youthful levels. But that's not what you're saying, but it was tested by blood test. And so I'm trying to blur your conception that you have an elevated DHEA and androgens, because I'd be really suspicious if you were, and I'd be really suspicious that it was a problem. And I can guarantee you, by 3 years into menopause, we don't know your exact age, 3 years with no period, you will not have an elevated DHEA or testosterone. You have a low DHEA and testosterone. And most women these days that we test, they're low in DHEA, they're low in testosterone midlife. So, a lot of different ways to look at that. Here's the bottom line. You want to find a healthcare provider that has taken a very special interest in treating women with hormones. And you really want one that does the 24-hour urine hormone testing, because this will sort out this thing so well. And I'm not saying other testing, not the urine 5-point testing, not the salivary testing, not blood testing. Blood testing is fabulous for so many different things. Oh my God, I've done so much blood testing in my life, but not for women who are being treated with hormones or women in menopause.
Right.
So, yeah, 24-hour urine hormone test. So your job, questioner, is to get some expert advice. Come join the menopause method. That's the only thing we do is we specialize in treating women in menopause with bioidentical hormones, and we'll help you sort that out. Now, lo and behold, we're now developing a men's segment, and we've got someone on board who's developing the teaching program for our providers. So we look forward to that, because I'm a man and I'm being treated by that gentleman, and this is one of the things in my program.
I'm sending Daryl over real soon. As soon as he gets back in.
You have elevated DHEA. I'd say don't get bent out of shape. You've got one job to do. It may not even be significant. It's extremely unlikely that it's anything rough, and even the rough stuff can be handled. So
even the rough stuff, yes.
Yeah, and because it ain't that rough. I mean, from a medical point of view, you talk to someone who's dealing with this every day, it's routine for them.
Right.
So, but your job is, once again, I know I'm repeating myself because it's every woman's job, is go shopping and find a healthcare professional, physician, nurse practitioner, who's choosing to specialize in treating women in menopause with compounded bioidentical hormones. If you do that, thank you. If you do that, that's what you need to do. Then they'll take it from there, and you'll figure it out together.
Yeah.
If you're taking other hormones, that tells me that you were somewhere in menopause. So that DHEA is something just needed to check it out.
Well, she's wondering.
I doubt that there's a significant elevation of DHEA, and it can be sorted out beginning with the 24-hour urine hormone test.
Okay. Well, thank you very much for that answer. And this second question is piggybacking on that one, but from a different questioner altogether. And she says, can Dr. R explain why you, Dr. R, do dose with DHEA and testosterone? So many doctors where I am do not use DHEA and testosterone, nor will they. I mean, there's just no way, she says. Um, that's one question. And then she asks, then what would cause acne? You know, with both of those, either taken separately or together, even in small doses. But that first part of the question is the one, why do you, Dr. R, like to use testosterone and DHEA along with our biased and progesterone?
I love this question.
Mm.
It takes us into the territory of one of the most important things that we do. And I will now describe.
Thank you.
One thing in medical school and even in postgraduate training, such as in those who are specializing in women's medicine, such as gynecology, for example, we were not introduced to proper hormone testing. And that's 24-hour urine hormone testing. And without 24-hour urine hormone testing, you cannot see what's going on in a woman. Now, blood testing in a young woman can be useful. It can get you in the ballpark. You can, for example, see declining hormone levels as a woman ages. Oh, let's talk about that. A woman and a man, we all have our peak gonadal hormonal output plus or minus the age of 20, plus or minus 2 years. Testicles in a man put out our maximum testosterone plus other hormones, DHEA, for example, at the age of 20 plus or minus 2 years. Women's ovaries put out 4 hormones, the estrogen family, progesterone, testosterone, and DHEA. Oh, look at that. The ovaries put out testosterone and DHEA. Oh, look at that. Testosterone is not a male hormone. It's a human hormone. Oh, look at that. Testosterone is as important in a woman as any hormone in a woman's body.
You're going to get a fight from some doctors on that one.
I will tell you that. But one of the main reasons that also is figuring into this is there was a stroke of lightning bolt of terror into the human population in 2002 that hormones could cause breast cancer. That was false reporting. The actual study that was being quoted did not show an increased risk. Initially in 2002, the Women's Health Initiative showed a reduction in risk by the use of horse urine-derived estrogens, Premarin, 50% of which the human female has never seen, the most popular and profitable drug of all time up to that date was Premarin and Prempro. There was a 1.26 relative risk with Prempro, but that was stated in the paper statistically insignificant.
Right, 0.
Yes, so we didn't have any information that caused increased risk, because in science, statistically insignificant means it has no meaning.
Right.
But that's not what the press got a hold of and blasted out. That's not how they interpret it. That's not how a lot of doctors interpret it. So we're once again hearing the story from a questionnaire of physicians being greatly concerned that they could be doing harm by treating women with hormones. And that matters to physicians.
Of course.
We're schooled in first, do no harm. So you can imagine when a physician learns that the most popular and profitable drug of all time, Premarin and Prempro, 40% of women in menopause in the United States were on this. That's 18 million American women were on Premarin and Prempro in 2002, prior to that study coming out. And doctors get this false information that explodes throughout the media that they could be causing a woman to have increased risk of breast cancer, even though that's not what the study actually proved. It scared them. So this whole field called treating women in menopause, unlike any other field in medicine that I've ever experienced. Neurology didn't get its growth stunted. Orthopedic surgery didn't get the major body blow that stunted its growth and made it disappear. Endocrinology, you name it, internal medicine, gynecology, it didn't get this body blast that made everyone afraid to go into the field.
Right.
And so, unlike all these other specialties, at a time when specialties were rising as they should have, as they should be, rising and rising and rising specialization, you need to. Now, there was no specialty in treating women in menopause with hormones because it got blasted and everyone got afraid. So there was no phenomenal development of the expertise base going on. So when you hear comments like this, they're common because doctors got scared. Now, fast forward to 2017, when the original Women's Health Initiative Study Committee that published the original Women's Health Initiative comes out with a retraction, publishing it in the original Journal of the American Medical Association that they published the WHI in, saying after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke. And as described in great and amazing detail in the book Estrogen Matters, when you met the author, because the author was a friend of your father's, an oncologist named Avram Blooming and his partner, his writing partner, Carol Tavris, PhD, come out with a book called Estrogen Matters, and they're really laying down the science. And what do they show? That women who are treated with Premarin or Prempro are at less risk for developing breast cancer, heart attack, and stroke than women who are untreated. Now, we're all at risk for all kinds of diagnoses, thousands of them. We're all at risk for cancer. As a man, I'm at special risk for prostate cancer, and there's reasons for that. Women are at special risk for breast cancer, ovarian cancer, and uterine cancer, and there's reasons for that. However, women who are treated with Premarin or Prempro, of course, urine-derived estrogens, or combined with this really molecule that I'm not a fan of at all called the progestin that has problems all of its own. Look up Phyllis Bronson and the brilliant work that she's done on exposing the difficulty with progestins and progestins in the birth control pill. Yeah, women treated with Premarin and Prempro are at less risk for breast cancer, heart attack, and stroke than women who are untreated. Women who've had breast cancer and had the breast cancer properly treated, they happen to be at an increased risk for recurrence than a woman does from getting a brand new breast cancer. Yet women who are treated with Premarin and Prempro are at less risk of recurrence if they're treated with Premarin and Prempro than if they're not treated at all.
Right.
Hormones. So I know that I'm sort of going wild here with, a very, very important question, but I want to get us back to testosterone and DHEA. Here's what I can guarantee every woman on the planet Earth. That's quite a statement. It's a written guarantee. That's not the kind of reckless statements that it's usually wise to make. So let me put it another way.
Edit.
Where's our editor?
Right back there somewhere.
That every single woman that I've tested, and this is well over 1,000, who are 3 years without a period, are absolutely low in testosterone and DHEA. Not a single one. And back in the day, like 25 years ago, when I first started doing this, treating women in menopause, there seemed to be a certain number of women who would enter into the perimenopause and they'd get a slight boost in their testosterone. In fact, they could get even some facial hair from that boost, or some acne or oily skin, because it was a way that their ovaries and their adrenals could compensate for the cascading low estrogen, because a woman's body can convert testosterone into estrogen. So you can get a little bump up in testosterone. So we didn't, back in the day, we didn't automatically treat women in the perimenopause and early menopause with testosterone. We'd hold off because we knew that there was a small percentage of them that would get a little elevation. And if we gave them testosterone, they get facial hair, oily skin, acne, and stuff. But my God, that's become so much more rare in my experience, that women enter the perimenopause or early menopause with a boost in testosterone. They've worn down their ovarian production and adrenal production of testosterone and DHEA. So they're not putting out elevated levels. Now let me tell you about testosterone. I'm a senior medical student sitting in the University of Michigan Medical School Hospital, University Hospital, a mecca at the time for medicine. I don't mean to use that word mecca in an inappropriate way, but it was a center.
Yeah, I could see where it would be.
And we used to get these lunch hour lectures from experts in this field or that. And these were very, very profound and esteemed professors, tremendous respect for them. And we get a lecture from a gerontologist one day. And the gerontologist, and I remember his words, he's saying, "You're senior medical students. You all know 1,000 diagnoses. Isn't that terrific? Let me tell you what's really happening to older people. They are losing their muscle in a process called sarcopenia, and they're getting to where they cannot stand or walk with stability, and they fall onto their osteoporotic hips, and they die." Because back in the day, there was really no good, excellent treatment for that. He said, "So you want to do something for the elderly? Help them preserve their muscles in their bones." Now, back in that day, there was no knowledge that muscles are preserved by what? Well, everyone knows exercise matters. But here's what everyone doesn't know. Androgens, the queen of the androgens, testosterone. Forget that what you believe. If you're a woman and you believe that testosterone is a male hormone, you got to turn your brain around. We got to work the dials. If you grab your ears and you turn one ear clockwise and the other ear counterclockwise, I'm pretty sure this new method that I've just invented will reset your brain, and you'll realize that testosterone is a female hormone. What do you think, Carolyn?
I'm going to try that. I'm going to try that with a lot of things actually today. I don't know about testosterone. It's a good exercise, but yes, I agree with you 100%. And you taught me this.
This method of resetting your brain about whether testosterone is a male or female hormone may not work exactly, but it might, so that you'll know that testosterone is a crucial hormone for you to receive for your whole life. We treat every single woman in menopause with testosterone and DHEA because they're all low sooner or later. We used to hold off, like I was saying, and wait until we did the first 24-hour urine hormone test, therefore dialing in biased and progesterone, and then we do the 24-hour urine hormone test, and then we see what the androgens are, what testosterone and DHEA levels are. We're not doing that. There's so many symptoms of low testosterone, like if you are developing flab in the triceps area, or just sit down on the floor, lie down on the floor, and then get up. Are you springing to your feet like a 16-year-old? Or are you finding you're having to use your arms and it takes some strength to get up from the floor? You're losing muscle in sarcopenia, and everyone is. And it's crucial that you get on the proper levels. And this is another part of that question. The reason people feel like they're just shooting in the dark, and they are, with DHEA and testosterone, is they're not doing 24-hour urine hormone testing. once a physician or nurse practitioner learns how to do 24-hour urine hormone testing, you see where a woman's at. And we've got reference ranges, and we don't go into youthful levels because we don't need to. Now let me tell you the punchline, and I mean this is the punchline, because I'm a physician. I've worked with people of all ages. So I get a sneak preview of what happens to women in their 70s, their 80s, their 90s. I see what happens to them. And here's what happens. Lo and behold, it's exactly what my medical school professor taught us. They lose their muscle. They have to change. They have to get into a cane. Then they're going to shift to a walker. And then there's this big moment in their lives where they have to go to the wheelchair. And for those who can afford it or get public assistance, that's the defining moment where you get to leave home and go into an assisted living facility and nursing home. And it's one of the major causes that women have to do that. When you couple that with there's loss of bladder control, oh, that's not pleasant. You lose bladder control because of loss of hormones that support the health of the vagina and irritate. When you get vaginal atrophy, you wind up irritating the opening of the bladder, the urethra into the vagina. That's a recipe for a lot of difficult things, including losing your urine. And when you couple that with the sarcopenia, the muscle loss of the main muscle that holds up the uterus and the bladder, it's a pelvic floor muscle. It's like a big cup. It holds everything up there. That's the levator ani. And when that gets sarcopenia, the bladder falls and the uterus falls, and that's how you get incontinent. And when you couple that with vaginal atrophy, and that's when many women have to use diapers. So what gets a woman into assisted living facilities and nursing homes? Those aren't the only reasons, but they're probably the most major reasons why a woman makes that shift out of her home or her family's home, where she can be taken care of and she can contribute to the family. That's what happens for all of human history. The grandmothers weren't put out to pasture. They were an integral part of the family home and contributed majorly on so many levels for so many reasons.
Generational thing. It was beautiful.
Yeah, well, that's changed. And so I'm mentioning this because when it comes down to it, what's testosterone and DHEA about? Nursing home, assisted living facility or not, for so many women. It's not the only thing, but it's one of the major things. So it's so important for you to preserve those muscles, and you want to start as early as you can. But I started treating my mother-in-law at the time when she was she was 86, and she got her muscle strength back. Mm-hmm. And she was using a walker. And then after treating her, I mean, in the interval, she wound up falling and fracturing her shoulder and her pelvis and being in rehab for 3 months. Not pleasant. Mm-hmm. And then when she got out of rehab, she was back in the walker, and we started treating her with testosterone, and lo and behold, we have a video of her sitting on a low couch, not a low couch, with her arms outstretched. Mary stands up with this huge smile on her face, no hands. Look, Ma, no hands. And so it's never too late. And so what's the moral of the story? Get that testosterone and DHEA right, as right as you do get your estrogen and progesterone and thyroid if you need to. These are the most powerful biochemicals of your body, which means you've got to find someone who really has taken this on as a specialty, knows how to do it. And one way you can sort them out is if they're doing 24-hour urine hormone tests. They've been willing to go on the educational ride, to go through a rather significant education to learn how to interpret these 24-hour urine hormone tests. So there's what I have to say this morning about testosterone.
Thank you. Thank you very much. You know, I where I work, I do see this happen often. I have to kind of be quiet But it's really sad to see someone go to the cane, then the walker, and then I see them in the wheelchair, and then they're moving.
Yeah.
Where are they moving to? I know where they're moving to.
Exactly.
Yeah. So, yeah, it's preventable. A question came up, and I would like to ask it, and I'll move on, because this other question is important as well. But it says, I just don't see how a woman can maintain muscle mass and lose weight with the estrogen levels you keep women with at your protocol. I feel like you don't address this. You address all the benefits, but never address the needs. And while I do understand your basis for keeping levels at what you suggest due to the apoptosis and breast tissue. Not sure I understand the ending part of that question exactly. I just don't see how a woman can maintain muscle mass and lose weight with the.
You know, I'm willing to answer this question if the woman will, for next week, submit more information about herself. There's too many mysteries in here.
Okay.
Like what her estrogen levels are.
No problem.
Yeah, this is I don't even know what she's talking about. How the estrogen levels we keep women on.
Right.
I don't know that she could possibly know what
Right.
level we keep them on. You have to understand what young women test out at. Let's say estrogen levels. Young women vary as to how much estrogen their ovaries put out. We're all individuals. There's a wide range of what the ovaries put out as far as estrogen goes, for example. Like some women, they only need this much estrogen, so to speak, whereas other women, to regularly menstruate, to be fertile, to support a pregnancy, they need this much. But anywhere in between here depends on the woman. But there's a variable level. But in general, we know what young women have estrogen levels when they're healthy and they're regularly menstruating, for example, and they're fertile. They're somewhere in between these two levels. I'm not naming the numbers. They're not going to help you, but they're somewhere in between these two levels on 24-hour urine. Well, menopausal women thrive right below that. You get all the protection of bone and vagina right below that. So these estrogen levels do not cause sarcopenia, nor do young women who have robust estrogen levels. The robust estrogen levels don't cause muscle loss. So I would like you to resubmit your question so that we can get a little more understanding of what exactly it is you're asking for yourself.
Yeah, thank you. And I'll go ahead and I'll reach out and we'll see if we can't get that question better. Thank you so much, Dr. Rosensweet. So, good morning, Rod and Jenny, Andrea, and Eva, I believe, and Kathy and the other Kathy and Katrina, everyone who's here, good morning. Next question comes up, piggybacking on our last question. I am trying so hard to find a way to get the 24-hour urine test, and I simply just cannot seem to do it. Also, all of my physicians that I have thus far seen are adamant that I do not need progesterone due to my being, as we call Sermeno, a surgical menopause person. She had a radical hysterectomy, full hysterectomy. They all say that I do not need progesterone as it is the cause of blood clots. Not progestins, but progesterone. So she has two questions. She's wondering how the heck she could get the 24-hour urine without the support of her doctors, if that's possible. And also what your thoughts are in regards to progesterone for a woman who has had a radical hysterectomy and blood clots.
Yeah. The they that she's referring to, they all say, I don't need progesterone, and they are all adamant about it, are not specialists. They're not specialists in hormones, or they wouldn't say that. These hormones whether it's thyroid hormone or adrenaline or cortisol or estrogen or progesterone or testosterone or DHEA. These are the most powerful biochemicals in our bodies, men or women. And they have multiple functions. And as progesterone was being uncovered and looked at, initially, it was believed that progesterone was really about pregnancy. Progesterone, progestational, gestation being pregnancy. Well, the progesterone levels are astronomical during pregnancy. They're super high. They do, along with super high estrogen levels comparatively. So, and then it was also seen that if a woman did not have adequate progesterone to balance the estrogen, and she had a uterus, the uterine lining would overgrow or would continue to grow even in menopause. If a woman was being treated in menopause and she had a uterus and she was being treated with estrogen, she could bleed again. She could have something that simulated a menstrual flow. It's not totally natural menstruation. And it was discovered that if these women were treated with adequate progesterone, they didn't use progesterone, they used what I would call a biochemical manipulation of progesterone that could be patented, because you can't patent a molecule that's present in the body. So they mess with these molecules so you can get a patent on it, and then you can make the big profits. They were using progestins, and they did discover that adequate progesterone in a woman who had uterus who was being treated with estrogen did not form an excessively thick endometrial lining and did not menstruate. From then on, it's all fantasy. Pardon my use of the word fantasy in a discussion about medicine. I'm saying that people who think that women don't need progesterone are in fantasy land. They're inventing this. So it was then believed if a woman doesn't have a uterus, why should she possibly use progesterone? Well, I'd like everyone out there in the audience to raise your hand if you cannot sleep unless you have progesterone. I can't tell you, 25 years treating women in menopause, there's a certain percentage of women that they cannot sleep. They lose their progesterone, they cannot sleep, uterus or no uterus. Because progesterone, like every other hormone, has multiple effects. There's only one hormone, there's only one biochemical I know that stimulates the cells that produce new bone, called osteoblasts, to lay down new bone. That would be progesterone. That's the only biochemical I know that does that. Estrogen preserves bone, but it doesn't do it that way. It slows down the cells that break down bone in the recycling of bone, a very natural biochemical process. So when you lose your estrogen, you get osteoporosis because the cells that break down the bones are going unopposed. So progesterone, there are so many women in the perimenopause, there's so many young women who are menstruating that have an anxiety that doesn't totally make sense. Yes, life has its emotional challenges. Yes, we all have a lot to do to acquire information and tools to do better with our emotions. And what a powerful acquisition that is, information and tools to help with your emotions in your mind. Oh my God, it's amazing. However, there's a lot of young women that their anxiety is like the forest fire of anxiety is being flamed. Is being used by the winds, by these amazing winds called no progesterone. And you give some of these young women, you don't give them Xanax, you give these young women progesterone and they calm down. I feel good again. I don't have anxiety. I feel good again. I feel myself again.
Right.
And you can multiply this times manyfold for women in menopause, that they're strong women leading good lives. And yes, they've had, all of us, males and females, we have emotional challenges that come up from time to time. But there's women who go into menopause and they get anxiety. And it doesn't even make sense to them, because they're leading decent lives and they never anxiety under the same life circumstances before. They get anxiety, you give them progesterone, bye-bye anxiety. You don't give them Xanax. You don't give them SSRIs. You give them progesterone. And I mean, there's women who have extreme anxiety to the point where they're saying, I feel crazy.
Yeah.
It
Yes.
doesn't make any sense, because they're empowered women leading good lives. And out of the blue, they start feeling insane. You give them progesterone and they feel better. No one can tell me that progesterone doesn't have multiple and critical, like every other hormone, effects all over the body. And this big time. If you didn't get enough B6, a vitamin, gradually, subtly over time, you'd experience a low B6 and its effects. And they run silent and they run deep, but they're there. You take someone's hormone away. Oh my God, these things are so powerful that you get powerful problems when you deplete the hormones. And progesterone is 100% up there. You want progesterone, women, as much as uterus, no uterus.
Gotta agree.
Progesterone as much as you want estrogen and testosterone and DHEA and thyroid hormone and cortisol and adrenaline.
Absolutely. And you did a wonderful interview with the wonderful Jim Hernser, who, made such a great comment when he said, when you're doing the doctor shopping, you just say, okay, thank you very much for your information. I appreciate your time, and bye.
And you call on that physician to do what they do best, and you disregard the rest.
Yes, disregard the rest. That's
and that
right.
physician is well trained and has many skills, but you cannot venture into the world of the most powerful biochemicals exist, hormones, and not do so embracing that. I mean, it took me 15 years. It took me 10 years to get good at it. That's studying, that's learning, or as we do in medicine, we see 100 or 500, or at the 500th patient that we've been treating, we start getting good at it. You talk about an orthopedic surgeon. How many hip replacements does an orthopedic surgeon have to do before they say, wow, I'm getting this.
Right.
I'm getting good at this.
Right, exactly.
And you can name that for any medical specialty. Well, it's not different with hormones.
No.
It was about the 100th or 150th 24-hour urine hormone test that I was reviewing with the laboratory director as I continued to learn that I started to go, wow, I'm starting to get this. I'm starting to understand this. It's like anything in medicine. That's why people do residencies. So, enough.
Yeah, what you gonna do? Hormones are so important. I'm just hoping and praying that more and more and more doctors, well, I see it. A lot more doctors are embracing menopause as a specialty, and I have such gratitude for that. Our last question, and then there are a few that we can bring out here, and this really, they're all piggybacking on each other. This is from a friend of mine, and she says she's an oncology nurse, actually, and she said, I was back in the day on the estrogen patches at the highest dose, and I felt great, and I was also taking progesterone, an oral cap. I ended up with breast cancer. She did have that breast cancer treated, and she says, I want to go back to what I was using then, but I'm nervous due to my breast cancer, and I really need some reinforcement that the combo that I took did not cause my breast cancer. My docs are wonderful and they're willing to treat me and they're kind, but it's me and it's my fear, and I know that. And so I was wondering if you could shed some light on that. Aw. I understand that question. I do.
Yeah,
Wow.
yes,
Yeah.
you do.
Yes, I do.
One of the most important things to address your question, questioner, is to read the book Estrogen Matters. And Carolyn, maybe you would post a link to that.
I can do that.
Estrogen Matters. It's by the oncologist Avram Blooming and his writing partner, Carol Tavris, PhD. They really dive into the science. There's over 450 scientific references in there. And Dr. Blooming has a tremendous personal experience with this. He has family members that have had breast cancer, that he's supervised the treating of these family members after they had the cancer treated properly. He treated them with Premarin and Prempro. And so he's got that personal experience. He conducted a study of who was in his study, women who had breast cancer. And what was the study about? How did they do when they're treated with hormones after the breast cancer is treated? And this has been, he's about to summarize, give another summary of this is many, many years in the making. And in the spring of 2022, he's going to be published in a major cancer journal about his findings. So we're all at risk for cancer. And like how I've always looked at it is, number one, and this is an opinion, no hormone ever caused cancer. These are natural molecules that we need for our health. No hormone ever caused cancer. Yet cancer has causes. And one way I like to look at it is I'll tell a patient, let's pretend that there was a videographer that took video of you from the moment you were conceived till the present. And that videographer, and did it 24/7. And that videographer had a magic editing button that they could press the button, and all the good stuff in your and that was filmed, all your happiness, your fun, your love, your pleasure, your successes, your laughter, all the good food you ate, all the good exercise you did, all the clean air you breathed, everything that was good in that video of your whole life, the editor pressed a button and it disappeared. It was edited out. What would be left behind is thousands of adverse events, thousands of them. We would see dietary indiscretions where you weren't feeding your body according to what was healthy for your body. You were going outside the farm there and you were eating things that had problems with it, including toxicity in the food, chemical toxicity and herbicides and pesticides if you weren't eating organic. All the toxic exposures you had in your household cleaning supplies, toxicity, chemicals that are very rough. Think of an insecticide. How much chemical do you have to expose a insect to for them to die? How strong does that chemical have to be for them to kill? Or herbs, how strong does the chemical have to be for you to kill weeds? All this is in it. This is rampant in our food supply. When I was in medical school in the mid-60s, the chapter on breast cancer was there, but it wasn't a prominent disease. It was just one more of the possible cancers. It's risen to a prominency because of the causes of all illness. Dietary indiscretions that challenge our health. Too much or too little exercise that stress us. Too little or too much exercise. Toxic exposure to toxic chemicals that are capable in the laboratory of producing cancer cells. and the elephant in most people's room, the biology of the stress response running amok.
Right, like the stories we tell ourselves.
Yes, and the fight or flight biochemistry that will do because you're waiting in line in the supermarket and someone's moving slow and you get all bent out of shape because they're not moving fast enough because you got to go to your next frantic endeavor.
Right. Frantic endeavor.
And then there's the mysteries because there's more to life than the basics of the causes of all illness being dietary indiscretions, toxic exposures, too little or too much exercise, which is stressful, and the elephant in the room, in most people's room, the amount of inappropriate stress biochemistry where you think you're fighting a saber-toothed tiger, but you're not. And
Feels like
those are the causes. Now I'm adding a fifth cause. There's some why people get illness, we can't explain them by ordinary means in this lifetime. You have infants that are alive for a few hours. You have children that get cancer. You can't necessarily explain it by understanding this lifetime only. So there is a mysterious cause. But these are the causes of all kinds of illnesses, including cancer. And the mechanics are not that obscure. You know, you get a cell that you provoke into having to adapt to a chemical that it doesn't like, and it undergoes mutation, and then the immune system is weakened, so it can't pick up that mutated cell, that cancer cells. We're producing cancer cells all the time, but a vigorous immune system goes, wait a minute, this is not us, and it just demolishes it. Unless you have immune system challenges, which is epidemic, as we're seeing with COVID. There's immune system problems in people, and COVID is really exposing it big time for our whole planet. So I'm asserting this, that it's not the hormones that ever caused your cancer. No. And any cancer that you ever have, a breast cancer, for example, those cancers begin 10 to 15 years prior to the time they're detected.
yeah.
When does the first cell that becomes the cancer mutate and have a chance to grow? 10 to 15 years prior. Now, the gray area is, what if you have an estrogen receptor site positive cancer? Are those the people who should never have hormones? No, it's a very gray area. And usually cancers have many different parts to them. Some of them look exactly like the parent breast glandular cell from which they arose. And a pathologist looks under a microscope, and they can't tell the difference. Is this part of the cancer normal breast tissue, or is it cancerous? Whereas other parts of the cancer they're called undifferentiated. They don't even look like breast tissue. And there's a wide range of undifferentiation in any given cancer. Those are the problem cells. They don't have estrogen receptor sites in them. They don't have progesterone receptor sites. They're so primitive that they never got so far as to develop these particular things that are present in normal breast glandular cells. So here's my point. Cancer matters.
Mm-hmm.
When we take on a woman with breast cancer as a patient, and we do so from time to time, and over 25 years, I've had many women. I'm still treating women I've been treating for 10, 15 years. They had their breast cancer. They had the breast cancer properly treated. That really matters. And one of the things that I've always mattered to me, for me to say yes to them being a patient of mine and treating them with hormones, is, have you done the life work? Do you have an idea of where that cancer came from? And have you addressed some of the causes? You don't have to be finished and done with your whole eternal evolution. You don't have to be totally enlightened. But we want it to matter so much to you that you took steps to address the physical aspects, the emotional aspects, the mental aspects, the life aspects of why you had cancer. And then if that's satisfactory, we treat select women with bioidentical hormones. And then the bottom line is, as the book, and I'm going to take us back to the book Estrogen Matters, by an oncologist who has been deeply involved with breast cancer, world expert on it.
He's amazing.
They show, Dr. Tavris and Dr. Blooming show in their book by showing the science that women who have had breast cancer are at an increased risk of recurrence of that cancer than a woman who's never had cancer is at risk for getting breast cancer. However, a woman who's had breast cancer and had the breast cancer properly treated is at less risk for recurrence if she's treated with hormones. And the hormones that the literature is most knowledgeable about is Premarin and Prempro. So just imagine what bioidentical hormones, these are molecular copies of what's in your body. And I'm not saying that's the definitive, and because Dr. Blooming has shown that, women treated with hormones, Premarin and Prempro, are at less risk for recurrence if the cancer's been properly treated than women who've never been treated, than women who are not treated with hormones. So that's the science, and I'm taking you back to the original thing that I opened this answer with, that purchase the book, Estrogen Matters, read it. Your fear, let's talk about your fear. We all come to Earth with fear. And it's one of our jobs to get skillful with fear. So one of the things I'd recommend is it's okay to have fear. It's what spiritual growth, it's one of the many moving parts of spiritual growth. It's to understand and heal the fear that's in us. And one of the first things that's needed to heal fear is to become conscious of it as you are, questioner.
Mm-hmm.
You're a human being who's admitted you have fear. That's step one. That's the most major step that there is. Without that, you can't go anywhere with healing fear. You're admitting it to yourself. That takes an act of strength that may not feel like that to you. It may feel quite natural to you, questioner I'm referring to, that you're aware and conscious that you feel fear. But I'm telling you, that's a very excellent, amazing, and necessary step to the healing fear. Here's step number 2. Allow that fear to be there. I'm not saying rush off and heal that fear. I'm not saying rush off and change that fear. It's like a child who's frightened and they run into their mother and they're crying and they're afraid and their mother sees that they're afraid. What does the mother want? What is the mother going to do? It's going to say, come here, honey, sit down on my lap. You can continue to cry. I see you're having fear. It's okay. We came to Earth with fear. The mother is compassionate and accepting of the child. Mm-hmm. That's what that child needs. Well, right. We need that skill just for openers. When we feel fear, we need to be conscious of it, and we need to be accepting of the energy that it is. Just breathe and feel the fear. Breathe and feel the fear. And do some homework, and you're starting at a good place. So that's about it. And oh my goodness, time doth fly. Did you ever notice that, Carolyn Shapiro?
I have to have a little marker in my notebook saying, keep an eye on the time.
Because it doth fly.
It doth fly. It doth. Doves fly. Oh, those are doves. No TH in there. It's always such a great hour, honest to God, and it goes by so quickly, but we get you on Thursday. So that's the goal. And I'll get you your questions, and I really appreciate everybody who's come up. Rod, I didn't make mention of you or Elsa, and Kim, good morning. Everybody, and Jenny, have a really good day and a half or whatever it is, and we'll be back with you on Thursday, and I hope, Andrea, that you and I can get your question sorted out so I can ask it. Okay? Have a great day.
You too. Good to see you.
Always good to see you, Dr. Rosensweet.
Bye-bye, Carolyn.
Bye-bye.